We cannot use it now.
Just
We
one
can
minute,
use
start.
it.
Start, just one minute.
Let's
Yes.
start now.
Yes.
Deepak,
Using
Yeah,
the
yeah, yeah, we are
webcam.
ready, we are ready.
It's on.
We are
Mine,
ready.
I'm not seeing. Okay. All right, I have to start now. Tell me when to start.
yeah. So just Jasmine, can we start and you can introduce? Yeah. So to
I'll
everyone,
have to go back to Zoom. No?
No, I have to do your presentation.
yeah. So first, Jasmine, can you
They
introduce?
won't see me at all.
No, but
Normally, when
Shalini,
we
I'll start
speak
with the
first and then
introduction
we
now.
share.
Just one minute.
start sharing the screen.
And can we start? I can only see you.
Yes, please go ahead. Go ahead.
Sure. So
We are ready,
Jasmine,
Jasmine.
can we
You can start.
start? You're giving introduction. Deepak, can you make yourself little mute? We want to start. Okay. Thanks. Yes. यज्ञेश को फोन करो देखो कितने लोग पूछे What happened? Jasmine, can you?
Shalini, can you hear me?
Yes, yeah, I can hear you.
Shall I
Please.
start now?
Yes, please.
Okay.
Start video.
Good afternoon, everyone. Good afternoon, everyone. Thank you for joining us today for this important and insightful webinar on premature ovarian insufficiency. We are thrilled to have you all here to delve into this critical topic impacting women's reproductive health. I am Dr. Jasmine Surana, consultant biochemist at Metropolis Healthcare Global Reference Lab, Mumbai. And I'll be your moderator for today's session. Please feel free to submit any questions in the chat and we'll address them after the presentation. It is my immense honor to introduce our esteemed speaker, Dr. Durusha, a truly iconic figure in the field of women's health. With over 4 decades of experience in obstetrics and gynecology, Dr. Shah is a trailblazer in fertility and women's health. She currently serves as the director of Gynaec World in Mumbai and is the founder president of the PCOS Society of India. She is also the founder and managing trustee of the Metropolis Foundation and a visiting consultant at Breach Candy Hospital and Jaslok Hospital, Mumbai. Dr. Durusha's achievements and contributions are truly remarkable, and it would take an entire day to fully cover them. She has been at the forefront of various key national as well as international committees and organizations, and is the current Vice President of the Asia Pacific Initiative on Reproduction. She has also been the President of Federation of Obstetric and Gynecological Societies of India. Dr. Shah has been actively involved in educating the next generation of medical professionals. She has authored over 200 publications and served as the editor of several prominent medical journals. She has also spearheaded initiatives that have made a significant impact, including the integration of reproductive health education in the school curriculum through the Ministry of Health and Family Welfare in India. Dr. Shah's tireless advocacy for women's rights and health has earned her numerous awards, including the Lifetime Achievement Award from FOGCI in 2022 and the prestigious FIGO Distinguished Merit Award, making her the first and only Indian to receive this honor. Beyond her clinical and academic work, Dr. Shah is passionate about social causes. Her NGO, the Women's Empowerment Foundation, addresses gender violence and women's rights, and her innovative app, Too Shy to Ask, provides critical reproductive and sexual health information for adolescents in multiple languages. Without further delay, please join me in welcoming Dr. Durusha to the webinar. Ma'am, we are truly fortunate to have you with us on this webinar. It is an incredible privilege to hear your expert thoughts on the important topic of premature ovarian insufficiency. We are eager to learn from your vast experience and insights. Thank you for joining us today. We look forward to your presentation.
And how to start the PPT. Good evening, ladies and gentlemen. I'm sorry my video is not functioning, so I cannot be seen, but you will see my presentation, which I'm going to share with you right now. Just give me half a minute.
Go, ma'am.
You just test him just 1 second. Yes, yes, look for double click to exit. Can you see, ma'am?
Come here.
Yes. It is not. That is their screen, ma'am. But you open ours, no?
Open it. Okay.
This is the one. Okay, now you can see.
Instructions.
Okay.
Okay. Let me start with premature ovarian insufficiency. Is there a hope for fertility? Now, here we are talking about primary ovarian insufficiency, which is also known as premature menopause, or it is hypergonadotrophic ovarian failure. It's a typical syndrome wherein menopause occurs before the age of 40 years. And if it occurs before the age of 35 years, it is called early premature menopause. And the woman will experience all the signs and symptoms of menopause, which normally women have in terms of not having a period, not feeling hot flushes, getting mood swings, dry vagina, inability to be sexually active because of painful intercourse, etc., etc. So these are area signs and symptoms which a woman may undergo. But when she's reached not had a period for over a year, then we say that she's got premature menopause. The prevalence is it's almost 1%, and it's what I'm going to refer to it as POI, that's primary ovarian insufficiency, because there have been cases wherein suddenly a woman may get pregnant even though she hasn't had a period for over a year, and one day she finds herself pregnant, because there is a occasional case where a egg may be released, and therefore we call it insufficiency. And it occurs approximately in 1 in 100 women by the age of 40 years, 1 in 1,000 by the age of 30 years, and 1 in 10,000 by the age of 20 years. It's various studies are giving a different prevalence, but I think in India it's around 1%, though unfortunately there has been a miscalculation wherein they have calculated all women who don't get their periods, and these are women whose hysterectomies have been done, and they have labeled India as having 11% as premature ovarian insufficiency, which is totally wrong because the data is done incorrectly. We know that the long-term issues are more related to causing problems with the cardiovascular disease, osteoporosis, fracture, depression, anxiety, and cognitive decline, which leads to a lower life expectancy. And in general, many women are totally unaware of what the problems can occur beyond menopause. And the reason is because of why a woman undergoes menopause is because the ovaries stop functioning at a particular age. In India, ovaries age at around 48 years, whilst if you see in the European countries, it may be at about 52 to 53 years of age. So Indian women reach menopause, normal menopause, at an age of about 48 years, whilst premature ovarian failure or premature menopause can occur before the age of 40 years, and usually the cause is idiopathic. We do not know what the cause is. There's no identifiable etiology, but genetically it may show issues related with the X chromosome. So you may have a monosomy, trisomy, deletions, translocations, and fragile X, or it may be autosomal dominant. It could be also because of some autoimmune conditions, and which can also cause autoimmune ovarian damage, or infections which occur at the time of puberty, usually when the cells are very active in the ovaries. And if you have mumps at that time, it can affect the ovaries, cause oophorytis, and it affects the function of the ovaries. It may occur because of tuberculosis, which is genital in nature. It may be malaria, cytomegalovirus, varicella, and shigella. The commonest cause is iatrogenic, where in the past, surgeons, when they removed the uterus, they would also remove the ovaries, thinking that it could avoid ovarian cancer. But they did not realize that by taking out early ovaries at an early age, that woman can have problems much earlier in life, as would otherwise happen after menopause. And chemotherapy, when we are giving to younger women, that is another cause of affecting the ovaries and ovarian failure. It may be radiation to the pelvis for some other reasons, wherein it could cause a problem, and pelvic vessel embolization, which is nowadays occurring quite often, wherein the uterine arteries are blocked to prevent, fibroids from growing or to cause heavy bleeding. And therefore, when we do that embolization, it's done under a CT scanner, which causes a lot of radiation and cause premature failure. So we have to be careful when we are treating patients and causing them problems which are called iatrogenic. And this is something we totally avoid now. We never remove ovaries in a young woman up to the age of 50, 55, unless they are diseased. But otherwise, ovaries are known to function till the age of about 60, 65 years of age. When chemotherapy and radiation is used, there's always preventive measures wherein we block the radiation to the ovaries by putting in a shield or moving the ovaries out of the field of the radiation. And when we use chemotherapy, we will use drugs like GnRH agonist, which takes the ovary from the mature state to an immature state, and then give the chemotherapy so that the effect on the ovaries is much less. And therefore, all this needs to be done in women if they need any surgery, if they need any radiation, if they need any chemotherapy. They need to get all these treatments done, see an oncologist before proceeding with any such treatment. Environmental toxins like smoking is a very, very important factor, and toxins in the air can also cause problems. So these are things we have to keep in mind. The symptoms, as I told you, could be vasomotor symptoms, hot flushes, night sweats, sleep disturbances, urogynecological and sexual changes. A woman may have dyspareunia. She may have infertility or reduced fertility. We are talking about premature ovarian insufficiency. So this is happening in women who are at 36, 37, planning a pregnancy and having inability to get pregnant. We also have, psychoaffective changes like insomnia, irritability, anxiety, depression, all what occurs in menopausal women, and it can also cause autoimmune disorders. So the clinical presentation can be varied, and a woman may reach different doctors for her same condition. She may reach the cardiologist for palpitations. She may reach a neurologist or a psychiatrist for her mood changes and irritability, insomnia, etc. She may use a sexual therapist because of her difficulty in having intercourse, and she may see a gynecologist, of course, for her fertility issues. Now, when it comes to the impact, there's a psychological problem, there's a poor quality of life, as I said. It has impact on the endothelial function, which is in the coronary arteries, causing an increased cardiovascular risk. So these are the long-term effects. What I spoke to you earlier were the symptoms, but these are the long-term effects: memory issues, increased risk of dementia, impact on bone health, causing bones to get weaker, and there's an increased risk of fracture, autoimmune disorders, thyroid disease risk, And of course, all the others we have seen. And mortality is definitely increased risk of premature death because the life expectancy is reduced, since all these problems are starting to them for them earlier in life, and therefore they are subjected to an earlier death. So in short, there is of course impact on fertility also, which is the area of my interest to bring up to you. But at the same time, when we talk about clinical diagnosis, wherein, of course, we do a good family history. If the mother has had early menopause, or we do an examination to see whether there are all signs and symptoms uh, of menopause based on whatever I have told you. And the investigations we do are the FSH, LH, estradiol to know whether it's a hypergonadotrophic status, so that you will get a high FSH, you'll get a high LH, and you'll get a low estrogen. Now, this you can do in a woman who's not menstruating and you don't know which day to do it. Otherwise, in women who are menstruating, we normally do these tests on the second or third day of the cycle. But when it's a lady who's already having a lot of no periods for 6 months, 8 months, then you have to do it on any day of the cycle. You can also do an AMH, which tells you how many oocytes are present in the ovaries, a prolactin to see whether the prolactin hyperprolactinemia is the cause of her amenorrhea, testosterone levels, because if she has high testosterone, then she could be also having a problem with with high testosterone, she would have amenorrhea, free thyroxine. So all these conditions wherein it causes a problem, we can realize that it will cause issues with periods. So the pelvic ultrasound and breast ultrasound is done, because if we are going to put this patient on estrogen therapy, we need to understand whether it's safe for us to give it to her. There is no lurking malignancy anywhere. We may also do a DEXA scan to know whether she has any osteopenia or osteoporosis. We also do chromosomal analysis for those women who are younger than 30 years, and we do a full autoimmune screen and for all kinds of polyendocrinopathies, because usually if there's an autoimmune disorder in one endocrine organ, it tends to occur in many organs together. So if you have to do the initial workup, if she's less than 40 years, she's had 3 months of amenorrhea, and we will first do a pregnancy test thinking whether she could be pregnant. But then if she's negative for pregnancy test, we do the TSH, the FSH, prolactin, and estradiol. If there is raised FSH and raised estradiol, it is not menopause, because the estrogen is high. It could be the mid-cycle gonadotrophin surge. So it's possible she's got 3 months no period, but probably she's going to have an ovulation soon, and therefore this is the kind of picture you will see. But if the FSH is high, which comes from the pituitary gland, and estrogen is low, which comes from the ovaries, it definitely suggests that it could be a premature menopause. But we still repeat the test in a month's time, because unless you do 2 readings, you cannot confirm the menopause. After 1 month, if again we have the same story, then we would say this is primary ovarian insufficiency. So the diagnostic considerations, as I told you, these are the different tests we do. As I mentioned earlier, it's all the same thing. Besides this, of course, we do the transvaginal ultrasound to see how the ovaries are looking. What is the volume of the ovaries? Is it the normal volume? Is it a shrunken ovary? How many eggs we see inside the ovary? Are we seeing nil eggs, or are we seeing what we would see at the age of, say, 35? We would see at least 4 to 5 eggs in each ovary, and the ovarian volume would be at least 3 to 4 ml. So then all these tests are done. And if you see over here, when you have a surgical menopause, the surgical menopause where the ovaries are removed suddenly, here is a surgical menopause, and here is a patient who's got premature ovarian failure. Now here you'll find that if a woman has got pregnant at an early age, a pregnancy occurs pretty easily. But by the time she reaches 35, and if she's undergone a premature ovarian failure, you'll find that she develops a lot of problems after that. And, osteoporosis, she may end up with a breast cancer, she has high blood pressure, she'll have metabolic syndrome, and all these kind of issues can come in. Now, if I have to predict whether a patient is likely to be going through a premature ovarian failure, we still don't have any method to say We come to know only when the patient has actually reached menopause, but we do not know when she's likely to reach menopause. We can only predict probably you will reach menopause, but we cannot say you're going to get menopause in the next 6 months. It's very difficult for us to say that. And therefore, there is a prediction model developed for detecting premature ovarian failure, which is to be used mainly in women who have got a family history of premature menopause. And then you do it in age between 35 to 40 years, where there is, probably her one ovary has been removed or she's undergone some surgeries on the ovary. It could have been an endometriotic cyst, it could have been a dermoid cyst. Nowadays, I find that, in young women, there are many gynecologists who would operate when they see an endometriotic cyst or if they would see a dermoid cyst. Now, it's not necessary to remove every endometriotic cyst or every dermoid cyst. However, even if it's very small, one can always do the tests which are required to confirm that it's not a malignancy. Some tumor markers can be done, a color Doppler can be done, a follow-up can be done. Idea is to save the ovary, because every time you operate on the ovary, you're increasing her chances of going into premature ovarian failure. And therefore, if a woman is still young, not married, we try and conserve as much as possible, treat her as much as possible medically, unless she's got severe symptoms of pain because of which she's not getting control through medication, then only we would think in terms of operating. Or if we find that this dermoid cyst is growing larger and larger, and it's scary that it may turn malignant, and therefore we would take it out. Now, there are some predictors of premature ovarian failure which have been assessed through artificial intelligence. And the idea which has come up is that one single predictor will not give us a good accuracy. And therefore, a model has been developed using all these factors, and they have come to a conclusion that the best the same factor which you can have is basically the AMH value, if it is very low, if the antral follicle count is low, or if on ultrasound you find that the ovaries are looking smaller than normal. If you see the figures over here, if there is a history of some complications or some surgery being done, if there's a history of mumps. So you see here, point 1, these are the best statistics you can get. Now, if you take only one, you'll never get a correct answer. But if you combine a history of some of the risk factors which I've mentioned earlier, then those are the risk factors you have to take into consideration and then make a provisional diagnosis. Now, coming to management of POI, how do we manage it? If the patient has got premature menopause, we need to give her menopausal hormone therapy. Of course, when we give her menopausal hormone therapy, the recommendations are that we should give it at least till the age of natural menopause, that is age of 50, so that you can prevent the complications of premature menopause. We must consider whom we are giving it to. So we need to investigate, make sure that she's got no risk factors which can cause her problems. Say, for example, if I'm giving hormones to a woman who's had deep vein thrombosis or who's developed clots, who's got a history of, an autoimmune disorder or SLE, I cannot give it to her because she's likely to develop clots with it. So therefore, it is important for us to select the right patient and give her the right route of treatment. Say, for example, a patient who's a high risk for developing clots, I may give her a transdermal therapy rather than giving her oral therapy. A woman may have problems with oral therapy, I can give her vaginal therapy. Or I can give her injectable therapy. There are various therapies available which we work on based on depending on whom we are treating. If a patient doesn't want periods, we give one kind of therapy. If she wants periods, we give another kind. So it depends on what symptoms she has, which combination we are giving, etc. I will not go into those details, but basically telling you that up to the age of 50 or natural menopause, we tell women to continue it, especially if she's premature ovarian failure. And at the same time, in women who are already menopausal, even at natural menopause, it's highly recommended to give it between 50 to 60 years because it has got more benefits than risk. Of course, keeping in mind that she must be investigated once a year with all the possible investigations. Then, of course, the second question comes is if she's young and she needs to get pregnant, then there are various things which we can do for her, which I will discuss a little more in detail. Then management of comorbidities, which may already be there. She may be having the symptoms, she may be having osteoporosis, she may be having cardiovascular issues, she may be having sexual dysfunction, genitourinary symptoms, or neurological problems. All this needs to be treated with the help of a multidisciplinary team or a consultant who's well versed with managing menopause. Then comes education, counseling, and psychological support because women are very distressed to hear that their ovaries have failed very early in life, and unfortunately some of them really have impaired self-esteem, emotional stress, and therefore we have to give them support in form of psychological counseling. So if you look at the therapeutic options which are today available to women with POI, as I mentioned to you, we can give them menopausal hormone therapy in the form of only estrogen or estrogen and progesterone or other products which mimic estrogen progesterone and can be used in different forms. Where infertility is concerned, we have to try our best to treat them with their own eggs. A lot is being done in the current situation, but in the past, all what we could do is, try IVF. If there are no eggs, then we have to use donor eggs. So here we have a situation where 25% of POI may ovulate on their own, as I mentioned to you earlier, but only 5 to 10% may conceive out of those 25%. It can be reversed depending on whether it is a primary amenorrhea or a secondary amenorrhea. Primary amenorrhea is something wherein, the woman has got no periods or she's menopausal right from day one. And the second is where she's had a secondary amenorrhea later in life, wherein some damage, some reason has occurred which can be corrected, and then she can starts getting a period. So primary amenorrhea is usually non-reversible, and for them the egg donation is the recommended treatment, and it gives us a 70 to 80% successful rate. While there are fertility prevention strategies, as I told you today, there are a lot of young women who are getting married late, not wanting to have a child very early, or they are not married, they are into careers, and then they have a late marriage and they force themselves to get married to whoever they think is the right person. But then the problem is that sometimes they make mistakes, and therefore it's important for these women today, at least keeping in mind that a young girl sort of in the past would get married at the age of 18, 19, have no problems with aging of ovaries, and by 25, 26 she had completed her family and she was done. So this problem never showed up in the earlier generation. But if we are talking about the younger generation where smoking is high, where many more women are working into careers and not wanting to have babies at that early age, they tend to delay their pregnancies or delay their marriages. In that situation, we believe in fertility preservation. We tell them to freeze their eggs so that when they freeze their eggs, the eggs are at a younger age. Even though they may want to have their babies 10 years later, they can use those eggs and conceive with those eggs. I think that's one of the best things which has happened to career women. And I think this is an advance of science which has helped many, many young women today. So coming to managing fertility, we may sometimes have to give hormones to the patient to help her. But once we know that the FSH is above 15 international units per liter, that is 15 milli-international units per ml, we know that this patient has a very, very low chance of conceiving. And we try 1 or 2 cycles, but then when we don't see any growth, even IVF cannot help them, then we suggest egg donation. Then we are believe that when these POI patients have a high FSH, we have to suppress them with some hormones and try with whatever we have to try with. But believe me, the results are not great if the FSH is above 15 MIU per ml. And therefore, assisted reproduction, which has come into the scene more than 45 years ago, and we find that that has come to the rescue of many, many women, to conceive a child. And today we know that with IVF, we can use donor eggs with IVF as a successful choice, where when we take eggs from a young donor, fertilize with the husband's sperm, create the embryos, and put it in the lady who's wanting to conceive. And this is again when I said when a woman is going to go through therapy for cancer therapy for cancers, we find that we must sort of freeze their eggs before they go through with chemo or radiotherapy. Then, of course, use of IVF we do with preconception genetic diagnosis, wherein we are trying to find out what is the genetic problem with those ovaries, if there is any, and therefore we prefer not to use the eggs of her family, like say of her sister or her relative who's very closely related to her and probably carrying some of the same genes. So we have to identify the gene mutations in the family because otherwise this will go on passing on to the next generation. So in short, we must make sure that we do a genetic testing before even using her sister's eggs or her relative's eggs. Then we do ICSI, we do TISA, PISA. These are all things done in short for men who have low sperm count. And ART banks exist. We can also use these tests for pre-implantation genetic testing, wherein we create the embryos. We want to make sure there's no genetic component in it. We take a biopsy from the day 5 embryo, send it for testing. And if the test shows that everything is normal, and if the whole exome sequencing also shows no problem, and if the microarray shows no problem, means there's no genetic issue, then we may, transfer that embryo. Depending on what we are sending for testing, we have to do the relevant test. We also have ART banks available today where we can freeze eggs, we can freeze embryos, we can freeze sperms, keep it for eternity as of now. We can use third-party reproduction wherein the woman sometimes has no uterus also, or she has, of course, no eggs. That, of course, she uses an egg donor. But surrogacy is meant for those women who don't have a uterus or a non-functioning uterus, where it's completely destroyed because of some, previous surgery done on the uterus, lot of fibroids removed, lot of scarring, many abortions done, lot of scraping inside the uterus, which has caused adhesions or genital tuberculosis or any other disorder which I've mentioned before. We can also donate a whole embryo to a couple where there is a male and female factor. And in women who don't have a uterus, we can do a uterine transplant, but a surrogacy is an easier option today, and therefore many of them go through that. So, in short, a woman's reproductive age can be extended. Women with premature ovarian failure or insufficient, eggs can definitely give birth either if they've frozen their eggs before, if they knew that there is a danger to their ovaries if they undergo some surgery or some procedure, or they're smoking a lot. That is the biggest danger today. And any woman smoking so many cigarettes a day, definitely there is an earlier menopause. So in short, egg donation becomes a medical therapy for women who want to get pregnant with POI. But if she doesn't want to get pregnant, we just treat her with medical therapy, that is menopausal hormone therapy, which I've talked about before. Now, if you look at the rates of live birth and implantation rate, with fresh eggs, you may get a live birth rate of, implant with fresh eggs, you can get a live birth rate of about 45%, and you get an implantation rate of about 53%. Whilst with the frozen eggs, you get similarly good results. It's not different. But on the contrary, if you use a frozen thaw cycle, wherein you take frozen embryos or frozen eggs, create embryos, and use a frozen transfer cycle, means you don't put it in a fresh cycle, but you create the endometrium in the next cycle. You create a fresh endometrium, put the embryos in, and the results of the frozen cycle show you that you get better pregnancy rates as compared to the fresh cycles. So these are the different studies which have been done. We have got our own data. Unfortunately, I have not added it over here. But even our data today shows similar results. And as the years go by, the results get even better. So here we've talked about getting donor eggs. I talked about freezing eggs, but you can also freeze part of the ovary today, and you can take bits of it and put it inside and freeze it. It's got a special technique to freeze it. So you can freeze human ovarian tissue. You can freeze the whole ovary. You can also, cryopreserve embryo cryopreservation by creating the embryos and putting them in, provided she has a partner. So today, a lot can be done where you can freeze eggs, you can freeze sperms, you can freeze embryos, you can freeze the ovarian tissue, you can freeze testicular tissue, you can freeze the whole ovary, and then afterwards, when the patient wants to be wanting that ovary back inside, you have to do a procedure wherein you thaw the ovary and put it back inside so that it is connected to the uh, uterus, and it can, I mean, it's put somewhere in some part of the body from where the eggs can be accessed. And of course, she has to still undergo an IVF procedure whereby the eggs are removed from wherever the ovarian tissue is. Hormones are given, makes the ovarian tissue respond. Eggs are picked up from there and then fertilized with the partner's sperms and put inside her uterus. So more than 200 live births after transplantation of frozen thawed ovarian cortex have already been reported by 2020. After that, there have been many more, and therefore today it's become a standard procedure to do. Coming to women who are, having very, very few eggs in their ovaries, or they're hardly seen. In our women today who are, over the age of 35 and are having difficulty conceiving, even through IVF, we may use platelet-rich plasma, which is separated from either the patient's blood or ready-made tubes are available with growth factors, wherein we inject it into the ovary of the patient, and it's called intra-ovarian infusion, which is going to help to regenerate the stem cells which are present inside the ovary. Now we know that there are cells present in the antral follicles present in the ovary, though they may not be seen on ultrasound, but there are many cells present, and we hope that by doing this we can make those cells grow, those eggs grow. This happens because of ovarian vascularization, because when you put in those growth factors and the platelet-rich plasma, it can encourage a lot of vascularity. It has been noticed that the AMH value increases, the antral follicle count increase, and about 7.54% conceive spontaneously after treatment. They did not require any further treatment. An intra-ovarian PRP and gonadotropin injection is given to those patients to achieve a successful pregnancy. So this PRP basically promotes the development of any primitive or primary follicles which are left in the ovary in the very primitive stage. And it helps to improve the ovarian microenvironment. It reduces the degeneration of normal follicles, and this accelerates angiogenesis and maturation of those eggs which are lying in the very pre-development phase. It has its own benefits and risks. It's easy to do, easy to handle, easy to create autologous from the mother's blood, patient's blood herself, good storage properties, and low immunogenicity if you use the patient's blood. But the risk is that it could cause infection, it could have intense cell proliferation leading to a malignancy, unknown detrimental effects to the embryo, which we still don't know what it can do. And therefore, the safety of PRP is not yet established. It's still under guidance from the ICMR, whether a center is allowed to do it or not allowed to do it. So you have to register for it. Beyond this, there is using your own eggs. There are some women who don't want to use a donor egg. They want to try with their own eggs. So they use that PRP. Otherwise, we can pull her egg out and, do a basically what women's eggs contain are mitochondria, which are the powerhouse of the egg. And the largest amounts of mitochondria are seen in the female egg, and they are present in the cytoplasm. And they are responsible for hardly 1% of the genetic material transferred to the mother, to the baby, whilst the nucleus transfers most of the DNA. Whilst this transfers only about 1% of the mitochondria transfer, the mother's mitochondria go into the baby. And if a mother has got a mitochondrial problem, it will definitely go to her daughter. The nuclear transfer is also can be done. So what is done is I'll show you. You can either transfer the nucleus or the mitochondria. Now what really happens is, if you see over here, this is the this is the mother's egg, the woman's egg, and it's a fertilized egg with the husband's sperm. Now here the nucleus is removed from the embryo, which is for fertilized egg, It is put into a young woman's egg after removing that young woman's nucleus, so that the genetic material of the mother here is going into this young woman's egg. And the cytoplasm of that young woman is the one which contains the powerhouse of that fertilized egg. After this nucleus of this lady is removed, the nucleus of this mother, this woman is transferred here. Then as this fertilizes and grows further, this is now the healthy mitochondria in this donor egg, which is containing the cell wall, the healthy mitochondria of the young woman, and this contains the nuclear material of the actual parent who's going to bear the baby. So there are many kinds of combinations you can do, and this is the three-parent baby recently approved by the UK government, and there they allow transmission. These are not allowed yet in our country unless it's under research, and usually this is approved mainly to prevent any genetic disorders. So things which are transferred through mitochondria, those disorders can be prevented by using a donor egg and removing that donor egg's nucleus. So you've got these various things you can do. Of course, you can do stem cell therapy, wherein stem cells are known to convert into any kind of cells they want to, and you get different kinds, different origin. You get the embryonic stem cells, the adult stem cells, you get stem cells from the bone marrow, from adipose tissue, from menstrual blood, from umbilical cord, amniotic fluid, and placenta. So you get whole lot of stem cells which you can remove from the body. And I'm not going to go into the details of this, but these stem cells can be then injected or converted into different kinds of tissue. I'm sure you all know there's a lot of research going on in the country, all over the world, and they have been used in different situations, like say for healing a heart infarct. They inject the stem cells and they hope that the muscle of the heart improves and works better. So therefore, these kind of therapies are being used in various situations, and we must remember that it can be used also during reproduction. So these are the various ways we can use them. I'll end my talk by giving you some take-home messages, that where fertility is concerned, egg donation gives the best results. Stem cell therapy has shown promising results against POI patients. Various biomaterials can be used to deliver the stem cells. PRP may be considered as an alternative strategy to use their own eggs. Clinicians should make sure that the platelet and growth factor concentrations should be ideal to get the best results, and they must make sure that those blood-borne samples are not carrying any infection. Then the mitochondrial nutrient and transfer therapy is being done in the UK now, for sure, of course, in certain centers. And we need to understand all this much more before we start using it in the private sector, because there's a lot of ethical issues involved. We don't know what the future will be, and therefore there are many who are doing these therapies, but they may not actually being allowed legally to do it. So we have to think twice before taking up these therapies, because sometimes it could cause more harm than help. So considering most of the research of these therapies has been performed on animal models. And considering the vast differences between humans and animals, we need to ensure that these new technologies can be safely and effectively applied to human beings. So in summarizing, I'd like to say POI may be spontaneous. If it's spontaneous, there's nothing much we can do but help her with the symptoms and help her with the fertility with donor eggs. Or it can be iatrogenic, which I've seen a lot of, and that is something we as physicians can definitely prevent if we are updated in our knowledge of what causes problems or what causes harm to those eggs. And fertility is POI can be prevented, as I mentioned here, and we must recommend women who are by the age of 32 in India, of Indian ethnicity, that if they have not yet found a partner in life, or if they are married and they still don't want to have children and they want to delay pregnancy, or if they want to, for some reason, they're having some difficulties between marriages, it's always advisable to these young women to freeze their eggs if they are don't have a partner, or if they're having a difficult marriage, and if they've got a partner with a good marriage going and want to, sort of delay it, then to freeze their embryos. And I think that would give them the best results in later, which will carry their own genes of their partner and themselves. So I thank you very much for inviting me to speak on the subject, and I'm sorry that we haven't been able to keep time because of some technical difficulties. And this is a little video which we have made, which is to create awareness amongst women. And we talk about no to smoking and obesity, but there was one on freezing your fertility. I think we can just put it up later on since we are lacking time. We have made these 2-minute videos where we talk about all these problems. And this is related to environmental issues.
You want the video to be run, ma'am?
Sorry?
You want the video to be run? Jasmine, are you able to hear me?
Yes, I can hear you, Shalini. I
Just
think
wanted to know
ma'am
if
wants to show the video for 2 minutes.
Okay, fine. So somebody, Deepak, can you click the video? Or Rochelle, can you click the video?
You can put it up on YouTube later.
Yes, ma'am. That I have downloaded it also. It's on smoking and those things. So,
I'm not able to stop it from here. Can you all stop it from there?
okay. Deepak? Deepak, are you there?
Yes, I'm there.
Can you stop it? Ma'am is saying that. Can you stop it? She's
Yeah,
not.
you can stop the video.
You can stop the video if it's.
Ma'am, thank you for the wonderful presentation. Your insights have been incredibly helpful and informative. Recent Indian study, which was published in August 2024, found out that 15% of currently married women aged 30 to 49 are in the menopausal phase, with the highest rates in Bihar, Andhra Pradesh, and Telangana. This highlights the urgency of addressing premature ovarian insufficiency, which is linked to increased morbidity as well as mortality risk. So, ma'am, today you have covered very crucial aspects of PIA, including the causes, diagnosis, and treatment options. And you have also provided a very concise overview of management strategies. And we have also discussed the emotional and psychological challenges faced by individuals dealing with this condition. So, ma'am, now we'll take few questions. Ma'am, what is your take on role of ovarian?
Sorry, I'm not able to hear you. Just a minute, huh? Why is this coming up?
Why? How this is? Maybe Rochelle. Deepak, how is this coming up? Abhini. Jasmine, you can speak if ma'am was not able to hear.
Ma'am, can you hear me?
I've got some other video playing going on at the same time. I don't know why.
Here it's not coming up, ma'am. It was playing for
Sorry?
just now. We cannot see the other video which you are seeing. Just few seconds back, वो था. But Abhini, it's clear now. Only your name is coming out here. रोशल एक बार चेक कर लेंगे क्या?
There's something else going on here.
We can hear your voice. Can you hear our voice, ma'am?
Yeah, but there's something else playing on the top. I don't know what it is.
Okay. That Rochelle will be able to.
I think we'll have to keep the questions for later. You can send me the questions, I'll answer them.
Sure, ma'am.
There's some disturbance here.
No problem, ma'am. Ma'am, on that note, we'll conclude today's webinar. We sincerely appreciate everyone for joining us today. A big thank you to Dr. Durusha ma'am for being with us and sharing her valuable insight. Once again, thank you all for attending. Have a great day and goodbye, everyone.
Thank you. Thank you so much.
Thank you.
Thank you, ma'am. Thank you, everyone. Thank you so much.